Thanks so much. It's an absolute pleasure to be here, and kudos to the organizers. It's really an outstanding event. So we've, over the past 60, 65 years, we all treat cancer here, or we've been somehow involved in cancer treatment. Although the drugs have changed, biomarkers have come and go, the fundamental approach has not changed in those 65 years. It's still a trial and error approach. We give a drug based on a biomarker. Our biomarkers are imprecise. Just look at PD-L1. Yeah, up, down. We still give immunotherapy to those patients, but we know that we're going to fail a large number of our patients. And so, wouldn't it be great if we found a way to be sure that a drug that we're going to give is going to actually work in the patient? That gives us the concept of up until maybe last 10, 12 years, we did not quite have the appropriate culture methods in order to test this. Now we're entering into hopefully the future where this concept of functional precision oncology. So what's your number? So over the past 10 years, we invested really heavily, initially with philanthropy and then through grants, on building a sort of a next generation live biobank in thoracic and upper GI cancers. So initially, we're just working with Morag Park when the group from Utrecht started coming out with the concept of patient-derived organoids. We were one of the first sort of adopters of this approach, and so the first 5 years we were really based on PDXs, converting them to organoids or just organoids themselves. We started that, but in 2018, a donor gave a significant amount of money, and we were able to really ramp up our live banking. And we've put in extensive amounts of energy and resources, like a lot of resources. This is expensive stuff. So over the past 5 years, we've done the usual banking with cryopreservation and FFPE tissue, serum, and so forth. But we're really ramped up is the organoid approach. So over the past, again, 5 years, my research used to be a lot of animals, a lot of transgenics. I've gone away completely. Only time I use a mouse is in order to get an organoid. For any of my research grants. But so through this process, we have built a huge bank of around 300 esophageal adenocarcinoma organoids based on the funding we received and the grants we received. I also, on my way to the esophagus in the OR, I have to push away the lungs. So at some time to take out a little piece of lung tissue and generate organoids as well, but our efficiency rate is not quite as good. This takes a lot of optimizing culture techniques and getting the right people around, and still our success rate for per tumor for organoids is still around 65 to 70%. Squames for the lung were quite a lot lower than that. We're probably around 35 to 40% for organoid generation rate. So what are organoids? Organoids are the sort of mini tumorlets. They maintain the heterogeneity of the primary tumor between 2,000 and 3,000 cells. They look exactly like them histologically. So on the left-hand side, you can see there's the bright field organoids, are sort of like the cultures. These are glandular tumors, the esophageal adenocarcinoma, glandular tumors, so they have a lumen. And you can see the first two, the middle on the left-hand side, the middle side show the actual organoids, and you compare that to the primary tumor, almost the same. On the top right, you can see this is an adenocarcinoma formally differentiated from a patient, and the organoid looks histologically similar. Genomically, they're similar as well. This is a fish plot map of showing that the clones are largely preserved. There is some selection. Clearly, there's some selection, just like there are with PDXs. But in general, the clonality seems to be it's polyclonal. The genomic clones seem to be preserved in our primary tumors. In addition, there's a large, Dr. Part will give you an incredible talk on that included at MSI High. We see that not only are histologically and genomically recapitulated from the primary tumors, these organoids, but also we find that microsatellite instability at the proteomic level is also preserved. You can see on the right-hand side, this is an organoid on the lower panel, organoid from an MSI High tumor. And you can still see there's a loss in the MLH1 and PMS2. So we're seeing that we're able to truly recapitulate that primary tumor in the organoids. More importantly, in order for us to even envision a functional precision oncology platform, it really has to respond the same way that the patient did. So these are organoids that we've treated. These are derived from treatment-naive tumors. So patients are undergoing neoadjuvant therapy for esophageal cancer. At the time, we're using docetaxel cisplatin 5-FU, and you can see this is a tumor derived prior to treatment in a patient who had a complete response. Can you hit the first video, please? And you can see after the chemotherapy, can you activate that first video? After chemotherapy, the top left-hand side, patient had a complete response. After 3 days of chemotherapy, the organoid just explodes like the Death Star. However, the next video, you can see a tumor that was an organoid derived from a patient who had a poor response and disease progression on chemotherapy. Press the next one. You can see over 3 days time-lapse video of docetaxel cisplatin 5-FU exposure. It just spins around. It's like it's tickled. There's no impact on the organoid whatsoever. And on the right-hand side, you can see the kill curves of ex vivo treatment of these organoids. And largely, these are on the green, those are the ones derived from patients who had a very good, either complete or near complete response to adjuvant therapy. You can see their kill curves is a very effective treatment as opposed to the poor responders or patient-derived organoids that were derived from patients who had poor response to neoadjuvant chemotherapy. So it seems to recapitulate the response to systemic cytotoxic chemotherapy. So can we use these PDOs to understand resistance and potentially salvage those patients who have resistant tumors? Can we turn those red lines into green lines, bring that down? So how can we do that? First, there's a whole bunch of my labs involved in various angles of this. Is some of the work that we're doing right now. We can use some variant-directed, some of the biomarkers, see if we can identify certain something in the sequencing data. This is single-cell transcriptomics. An example of a patient who had, you can see a CDK12 highly expressed epithelial cluster in the single cell from the primary tumor. The organoids at the proteomic level, it's preserved. You can see CDK12 expression on that organoid and do a small drug screen, CDK with a CDK12 inhibitor. You see that it's quite active. And it's actually synergistic. So we're converting that brown survival curve with DCF or docetaxel triplet-based triplets to a responding tumor by the addition of a synergistic CDK12 inhibitor. So unfortunately, for the diseases that I treat, which is mostly esophageal adenocarcinoma, we don't have very many variants that are targetable. So maybe there's a different way we can look at this from a different angle, help us understand how the therapy resistance is manifesting in that patient's tumor, and how can we overcome it. Another way to do it is to do, a variant agnostic approach. This is a high throughput drug screening. So this is example. Saves my PhD students, postdocs, mountains of time using a robotic delivery liquid handler system. You can do organoid seeding. We use 3,000 a library of 3,000 FDA-approved drugs, and we're able to test them all, single concentration, and identify which drugs could potentially be useful in this patient. So this is an example of some work from one of my current PhD students. These are 3 organoids. She used 3 organoids that were derived from patients that were resistant to neoadjuvant systemic cytotoxic chemotherapy. We used all those 3,200 drugs. We identify only the certain number of drugs that had inhibited 65% of those organoids. And you can see we start from 3,200. We identify the ones that had that were efficacious in all 3 of those poor responders. And you can look at all those 20 drugs. You look at the different targets. And initially, we wouldn't have chosen this from the variants. Some of these targets, we wouldn't necessarily really chosen those from the single cell sequencing or from the genomic sequencing. Keep an eye on IGF-1R. We integrate this whole high throughput drug screening with its single cell transcriptomics, then you're going to start getting a bit of a message on how to treat these patients. So again, we compare good responders to poor responders, single cell transcriptomal level. You can see they're sort of separated into 2 different clusters generally on the right-hand side, in the good responders and the poor responders. And if you concentrate on that little cluster 14, you can see that 14 down at the bottom right here. You can see there's a high IGF-1R expression in that cluster. So this analysis was informed by the high throughput drug screening. So we're integrating that single cell transcriptomic data with the high throughput drug screening data to get an idea of which targets we should go after. We have 20. We can't treat the patient with 20 different drugs. We have to choose which one actually works. So we find that the IGF-1R inhibitor has a lot of synergy with our docetaxel and 5-FU, and we can use that drug in our organoid drug scene and potentially give it to the patient. But what's the problem? Organoids are great and all, but there's a significant amount of overlap in the middle there. Some poor responders and good responders are coming to sort of cross over that line of the kill curves, implying that maybe there's some other factors that we're not accounting for in those patients. So what are the problems with organoids? It's still static. It's in vitro. Their chemotherapy concentration is not physiologic. You're giving a IC50s. It's not what we give to the patients. And there's no stroma. And we know, based on this is some work that we've done with Gary Nolan at Stanford, we know that tumor microenvironment can influence a response to therapy. This some data from one of my current students looking at fibroblast changes during therapy, how different calf populations predominate over treatment and maybe driving therapy resistance. So how do we incorporate all that into a functional cancer precision oncology program in order to know exactly whether or not patients are going to respond to chemotherapy? Some people out there say, "Oh, PDXs address all these issues." It addresses static in vitro, addresses you can give whatever chemotherapy the patients get. It has stroma. The problem with PDXs is it has murine stroma. That's like Frankenstein. It lacks an intact immune system, and there's a lengthy development. So it's really not good for you. May be able to do it in treatment. May be able to treat the metastases in 6 to 8 months, but really the timeline is not really good for functional precision oncology. That really brings me to the concept of the organ chip. This is a collaboration that we developed with Don Ingber at the Wyss Institute at Harvard. And what we're trying to do is recreate a patient avatar on an organ chip. So this is one that Don developed and is now licensed to emulate. And it is currently the most physiologically relevant stroma-inclusive cancer model system that we have. It replicates the physiological shear rates that we see in flow. It has a mechanical stress. When you take a breath in, you have your lungs expand, the cells expand and pull, and that mechanical stress also impacts biology. And also, you can give a clinically relevant chemotherapeutic dosage. So I'll give you just a couple of slides of how it's working. This is in development. This is something that we just put together due to an incredible amount of work from one of our postdocs, Sanjeev Pal. So what we're doing, we're using patient-matched organoids and calves. So we're taking the same patient, same tumor, and that's undergoing chemotherapy. We seed a luminal channel with organoids at the top. We seed the vascular channel with fibroblasts at the bottom. And we can flow chemotherapy through one of them. We can throw bile through the other side, bile acids on the top. So currently we've just optimized this for 2 cells with organoids and calves, but we are planning to go to a quad cell with TILs and endothelial cells. So this is what it looks like. We have to really recapitulate the same tumor. So this is from the same patient, 64-year-old gentleman with polydifferentiated adenocarcinoma. On the left-hand side, from a normal biopsy adjacent tumor, you can see we have a normal looking glandular structure, glandular epithelium at the top. On the bottom, you have the fibroblasts. On the right-hand side, you have this massive tumor that's grown onto this. This is after 7 days on chip. And we can keep these things going for weeks by continuing a media or blood or simulated blood through the vascular channel. And if you look at any pathologist will tell you, you compare this as a primary tumor from the same patient to the adenocarcinoma on the chip, it is the exact same cancer. It's really is recapitulated all the heterogeneity you see in the primary tissue. And then what about chemotherapy? So we can give the same slot as what we use primarily for adenocarcinoma of the esophagus. And we can give the exact same inpatient pharmacokinetic concentrations through the vascular channel, just on top of over the fibroblasts and ECM that they've generated. And if you can compare 2 different organ chips, the one on the left, top left, immunofluorescence is a chemosensitive patient. It was derived from a patient who had good response to chemotherapy at treatment naive. And the one on the top, on the right, is a resistant. And you can, after giving in chip chemotherapy, the exact same doses as concentrations the patients see. You can see on the bottom left, there's almost near, after 1 cycle, there's almost near complete resolution or destruction of the epithelial cells by maintaining the fibroblast. Whereas on the chemo-resistant organ chip, there's still maintenance or some response, but there's still maintenance of an intact epithelium. In electron microscopy, you can see the chemosensitive one just explodes. Basically the membranes are completely destroyed. So This is the same data using sort of quantitatively. You can see where there's a high release of the increased killing in the patients who've had chemosensitive versus chemoresistant, so a lot less repeated iodine and cytotoxicity assay. What else can we do with these organ chips? They really are little mini humans. If we give the chemotherapy through the vascular channel, you can also take the effluent from the vascular channel after they've gone through the chip. And you can look for plasma-based biomarkers of cytotoxicity and tumor burden. This is just a couple circulating tumor DNA. Clearly, we haven't looked at that yet, but these are some of the ones that the postdoc has examined. LDH, increased LDH, more killing in the chemosensitive than the chemoresistant organ chips. You can see there's an increased release of LDH. And a marker, plasma cytokeratin 19 as an antigen, tumor antigen for esophageal adenocarcinoma. We show that there is an increased release in patients with higher tumor burden. So the more cytokeratin 19 in patients, the more likelihood of tumor involved. The tumor is more greater tumor burden if there's a greater level of cytokeratin 19. So by the chemosensitive with the chemosensitive, look at the waterfall plot, the chemosensitive organ chip, you can see a significant reduction in the cytokeratin 19 after chemotherapy. That mirrors the RECIST criteria, the objective response rate in that patient. So it really mirrors the in-chip and in-patient response is exactly the same. So this is the last slide. This sort of shows this is what we've tried to develop. We're trying to develop it on a clinically relevant timeline, this whole process. We go from high throughput of the organoids, where we have high throughput drug screening integrated with genomic or transcriptomic variant data to help us give us an idea of which 5 or 6 drugs are the top hits. We take that to a more high fidelity esophagus chip platform and really hone down in 5 days. We know exactly which one of those 5 works in that for that patient. So our whole concept. Now we use this physiologically relevant cancer model system. We're using it for a bunch of grants, investigating therapy resistance, investigating carcinogenesis, but has incredible promise for both drug development and what we really hope to be able to use, and what we've been challenged by the Kidney Cancer Society and funded to do, is to bring this to patients in the next 3 to 5 years. So within 5 weeks from a biopsy, we know exactly what's going to work in that patient.